Hello and welcome to this Medical Jeopardy program entitled Updates on Chronic Rhinosinusitis with Nasal Polyps, Uncovering Epithelial Targets in the Upper Airways. We're honored to have participants from across the country here this evening, not only in this room, but also viewing online. A few important housekeeping notes for those of you in the room. This program is supported by an independent grant from AstraZeneca. To answer polling questions, please use the keypad provided. Your responses are anonymous and very important to the outcomes of this program. The information being presented is available online. The link is listed on the card in front of you. This card also provides links to valuable clinical resources, educational activities, and patient testimonials. As part of our ongoing efforts to evaluate impact and refine future activities, please complete and return the two-sided evaluation form before you leave. For everyone joining us online, the system will prompt you to answer polling questions. The information presented is located on the right side of your screen under the Handouts tab. The evaluation will automatically open in your web browser following the conclusion of the program. For our live audience, please use the question cards located on your table to ask questions. Ushers will be collecting them throughout the program. If you are online, please submit questions through the Q&A box on the right side of your screen. Now, let's give a warm welcome to our presenters. Dr. Tanya Laidlaw, Dr. Joseph Hahn, Dr. Flavia Hoyt. Enjoy the program.
All right, team, welcome to everyone. Unbeknownst to maybe you guys, you've all pre-chosen your teams, which we're going to find out about shortly. So we have our disclosures up for everyone to be aware of as we move forward with this for the three of us. And I think the learning objectives overall, we're going to get to all of them, but not all at once for sure. So in addition to sort of discussing and understanding the roles of epithelial cytokines in these diseases, in nasal polyps and in comorbid diseases, we're going to have a pretty big clinical kind of lens to all of this as well, so making sure that we can assess, evaluate, and treat our patients as well as we can with what's out there. We're going to identify some gaps, I think, in the clinical care as well. Looking through the clinical profiles of what we have right now for biologics, what we might want in the future, what we have emerging, and then really looking how to individualize the treatment plans for these patients as much as we can and the best ways to help them. We have two pre-test questions. I don't think this is a matters for the end of the day thing, but this is to get a sense of who's out there. So for this first question, this is kind of testing your ability to actually use your clickers as well, is approximately how many patients with CRSwNP do you manage per month? 1 is none, 2 is 1 to 5 per month, 3 is 6 to 10 per month, 4, 11 to 15 per month, 5 is over 16, or 6, I don't manage patients, I'm just here to learn a lot of stuff. Go ahead. All right. Second and last pretest question. Approximately how often do you now recommend biologic therapy for patients you see who have uncontrolled nasal polyp disease? 1, never. 2, a quarter of the time. 3, half the time. 4, 75% of the time. 5, all of the time. Or 6, I don't manage any patients with nasal polyps. I'm just here to learn some stuff. All right, so rules of the game. This is a Jeopardy-style game. Everyone has been self-assigned to a team, though you didn't know it. Dr. Hahn and Dr. Hoyt are your team leaders, fearlessly. Dr. Hahn's team yellow. So if you're at a yellow table, you are automatically on his team. Good luck to team yellow. All right, 1, 2, 3, 4 tables so far. If you are on a green table, you are automatically on Dr. Hoyt's team. Multiple green tables out there. Okay. So your team leaders will fearlessly go back and forth, politely, taking turns, and choosing the question, as one does on traditional Jeopardy. As we get to the question and the dollar amount, that will then open up the question that they've chosen. And I will read out the question. I'll offer you your A, B, C, D answers. And you'll have that same sort of 15 seconds to think about it, talk amongst your table. Don't Google the answers, stay real. And respond to the question using your keypad. Then there'll be a pause while you actually learn from our esteemed colleagues a little bit about the topic that was just asked, right? So if you didn't know the answer to begin with, you might realize at the end of a little bit of a didactic that you got it right or you got it wrong. And then at the end, we will reveal after the learning phase what the team was, who got it right. So there'll be calculations going on during the didactics, so then we reveal who won that question. The team with the highest percentage of teammates who answered is the one who wins. We've already been hung out backstage and done a coin toss, and so Dr. Han gets to go first. So Team Yellow already has an unfair advantage, and we get to choose the first category. All right, so here are the categories. We have alarmins in the upper airways. We have improving nasal polyp management, biologics for CRSwNP, and the unified airway model. So, Dr. Han, where do you want to start?
So, Dr. Laidlaw, I like to try 200 under alarmins in upper airways.
All right, he's wimping out, you guys. He's going top left. Fine, okay. Let's see. Alarmins in the upper airways it is. All right, get ready. Question. In the airway, which of the following cell types produces alarmins in response to triggers, such as allergens, microbes, and irritants? 1, NK cells, natural killer cells. 2, epithelial cells. 3, innate lymphoid cells. Or 4, T helper cells. All right, so far we have 80% on epithelial cells. We don't know if that's right or not, though.
Yeah, all right, well, let's take a look. So the audience is a very smart audience, and you are right. So we know that when you look at the alarmins, that's TSLP, IL-33, and IL-25, they're usually created mostly in the epithelium. Now, what triggers the release of the TSLP from the epithelium are different irritants like smoke, allergens, viruses. These things can cause the epithelium to get injured, then releases the TSLP. Now, majority of the TSLP does come from the airway epithelium. There are other cells that do create TSLP, like mast cells, eosinophils, and dendritic cells, but most of it comes from the epithelium. And these TSLPs then binds to the TSLP receptor, and that TSLP receptor is a heterodimer, which also binds to the IL-7 alpha as well. And then that after it binds, then it activates the JAK1 and JAK2, which then releases, then activates the STAT5 A and B, which then causes release of IL-5, IL-4, IL-13, and those then activate a lot of the cells. So we get maturations of the B cells, we get dendritic cells to mature and develop chemokines. We see that the T cells differentiate to become T helper cells, and then there's activations, mast cells, eosinophils, and macrophages. So great job. So let's see who won. Yellow, whoa. Yay!
Woo! All right, the first win. Do you want me to read the question?
Oh, okay.
All right, so.
So, sorry.
I'm sorry.
I think we're going to dominate.
Sorry for the sad loss for Team Green.
It's still early.
Team Green, get it together. All right, Dr. Hoyt, what are you picking?
Okay, I'm going to start small, but we're going to go big. So, United Airway Model for 200 will be our first.
Okay, let's see. Unified airway model for 200. The question is, which of the following sets of airway diseases share common pathophysiologic manifestations? 1, asthma and interstitial lung disease. 2, asthma and otitis externa. 3, CRS with NP along with allergic rhinitis. Or 4, CRS with NP along with otitis externa. All right.
Okay, great. Yeah, so I think most of those answers were green there. But CRS with nasal polyps and allergic rhinitis do share common pathophysiologic manifestations. And this is really what the unified airway model is about. So the unified airway model has been around for many years. And the idea is that upper and lower airway disease reflect a single pathologic process that manifests in different locations within the airway. So upper airway, we think nose to larynx. Lower airway, we think larynx and beyond. So the trachea, bronchi, all the way down to the alveoli. And the type of inflammation that we see is very similar in the upper and lower airway, although of course there are some differences. There is bidirectional provocation with allergens, but then we also know that other irritants and infections that trigger the upper airway trigger the lower airway and vice versa. And you can see here the disease processes that affect the upper airway in the top box and the lower airway in the bottom box. There's your allergic rhinitis and CRS with nasal polyps, also CRS without nasal polyps, non-allergic rhinitis, mixed rhinitis, and otitis media, not externa. And then in the bottom box, asthma and eosinophilic COPD. And then of course there's AERD, which is sort of the quintessential unified airway disease, Samter's triad, where you do have the eosinophilic inflammation in the upper airway, lower airway, type 2 inflammation that really drives much of what we see in AERD. And so supporting evidence for the unified airway model really comes from epidemiology. So you know that in patients with CRS and nasal polyps, about 70% of these patients have asthma. And then the reverse is true. So in patients with asthma, we have a large portion that have comorbid CRS with nasal polyps, about 40%. And this correlation is also true in allergic rhinitis. We also have evidence from pathophysiology. So in particular, type 2 inflammation is very prevalent in severe eosinophilic asthma, as well as CRS with nasal polyps, allergic rhinitis, NSAID, or AERD. And this is really characterized by the eosinophils, as well as the cytokines IL-4, IL-5, and IL-13. And then in terms of the actual functional and pathophysiologic evidence, we see ciliated epithelium and goblet cells in both the upper and lower airway. And then many of the cells that we see either related to type 2 inflammation on the left or type 1 inflammation on the right are there in both the upper and the lower airway when we're talking about inflammatory diseases of the airways. So one more important point, in terms of comorbid upper and lower airway disease, it really makes your prognosis worse in both the upper and the lower airway to have both. So there are higher rates of nasal polyp recurrence and corticosteroid dependence if you have both upper and lower airway involvement, more difficult to treat asthma and CRS with nasal polyp symptoms, and then these patients are more prone to asthma exacerbations. They have worse outcomes overall. And this is compared with patients who just have upper airway disease or lower airway disease. So let's see how we did.
Oh, yay.
Ouch.
It's okay. It's okay. It's early. We'll just wait for the bigger questions.
That's right. That's right. She's going to bring it home with the big menace.
All right. So
All
let's
right.
see. All right.
Doctor. Oh, here we go.
We're
Up
off
to
400.
400.
Okay, great job.
All right. Okay.
All right.
You can come back.
So since we're doing so good, I'm going to go a little bit, have a bigger number. So let's
Feeling
do
gutsy?
400 for a unified airway model.
Okay, let's do it. What do we got? Here we go. Okay. Question is, among patients with CRS with nasal polyps, what percentage have comorbid asthma? 1, 10 to 20%. 2, 25 to 35%. 3, 40 to 70%. Or 4, 75 to 90%.
You know, I think that's a little bit unfair question because Dr. Hoyt just gave a top.
Well, if the green team wasn't paying attention to her, they should have been.
I think this is like a, so it was just very fortuitous that I got the right question. So I think they just got a lecture on it. So yay, so everybody was paying attention. So 60% of the people got it right, 40 to 60%. And so it's not uncommon for patients with nasal polyp and asthma to kind of coexist. And so, when you look at chronic sinusitis, there are other comorbid diseases that usually go along with it. Allergic rhinitis is a very common one. And so, if you look at chronic sinusitis, about 40% of people have allergic rhinitis. If you look at chronic sinusitis with nasal polyp, it can go as high as 70 to 80%. You see that NERD or NSAID or ERD or NSAID ERD is also one of the most severe nasal polyps to control and to treat. And we see that it does make about 20 to 25% of patients with nasal polyp have ARD. And so those are some of the most difficult patients to treat. And as you heard earlier, that nasal polyp and asthma do coexist. And so in patients with asthma, nasal polyp, we see those numbers around 40 to 60%. And then, and we know that people with nasal polyp, if you have asthma and you also have nasal polyp, these patients who have nasal polyp tend to have more severe asthma. And lastly, I think something that's not recognized as much is certainly people with chronic sinusitis with nasal polyp also tend to have gastroesophageal reflux disease and even chronic or vasomotor rhinitis as well.
Oh,
no.
All right, good.
Okay.
Making a comeback.
Looks like it's a tie now, huh?
Oh, is that, with a single question. Green's tying it up. Okay.
Wow.
So, let's see, on that note, how gutsy are you feeling, Dr. Hoyt?
I think we can continue the trend of the bigger numbers. So let's do alarmins in the upper airway for 400, please.
Okay, here we go. All right, alarmins regulate epithelial barrier function and are associated with which of the following types of inflammation? Your options are 1, type 2 inflammation, 2, non-type 2 inflammation, 3, both type 2 and non-type 2 inflammation, or 4, neither of these.
Great, smart audience. So yes, it's both type 2 and non-type 2. And we'll start first with the type 2. Just thinking about the epithelial alarmins and the cytokines that they affect from a type 2 standpoint. So the alarmins, Dr. Han mentioned earlier, IL-25, IL-33, and TSLP are the major ones we're talking about tonight, and they're produced by the epithelial cells. And they cause an elevation in type 2 high cytokines, IL-4, IL-5, IL-13, and these tend to be produced mainly by the Th2 and ILC2 cells. And again, as we mentioned before, allergic rhinitis, asthma, and CRS with nasal polyps are all predominantly driven by this chronic type 2 inflammation. And then in terms of non-type 2, there also is an impact from the alarmins. And so you can see, because the alarmins act at the epithelium when triggered by any of these myriad of triggers, they cause the downstream inflammation by the Th17 cells that you can see on the left, which mainly produce IL-17A and IL-17E, also known as IL-25. And then on the right, you see the Th1 cell, which mainly acts through interferon gamma and TNF-alpha. And then other epithelial alarmins are GM-CSF and IL-8 that are produced at the epithelium and act directly on the neutrophils. So in this type of inflammation that's non-type 2, you'll see either a neutrophilic predominance, or oftentimes you'll see a paucigranulocytic, so not a real clearly identified inflammatory predominance of any one type of cell. And sometimes that's thought to be maybe because they're being treated and that's dampening the inflammation. Let's see who won.
Woohoo! Comeback. All right.
All right.
Good work, team.
Okay, all right, slow start. I'm just picking it up, Green. All right, so score is now, ooh, she's doubled you.
I know.
Sorry about that. All right, so Dr. Han, your choice. What are we doing?
Right. So let's go big. All right, let's go 600 for our alarmins in the upper airways, because I know our yellow team's going to get this one.
Okay.
All right.
It's a lot of faith in the yellow team. All right, which of the following might result from upper and lower airway processes? 1, airway hyperresponsiveness. 2, mucus hypersecretion. 3, the formation of nasal polyps. 4, all of the above.
wonderful, 86%, all of the above. And so let's kind of go through that. So we know that both the upper and the lower respiratory airway epithelium has goblet cells, and these goblet cells make a lot of the mucus because of the production of IL-13. And so we see that's why there's a lot of mucus secretion. We know that there's also, when their airway, whether it's upper airway or lower airway, when it's chronically inflamed and primed, it doesn't take very much for those epitheliums to be excited and cause hyperreaction. So whether it's the asthma or nasal polyps, these can easily get acute exacerbations. And as you heard earlier, a lot of the injury starts at the epithelium. And when you start having injury at the epithelium, you also have injury to the vascular structures as well. And when you have structures, when you have leakage of both the epithelium and the blood vessel, you get a lot of edema and you get a lot of swelling, which eventually leads to symptoms of congestion and even polyp formation. And then for the airway, we see that even the smooth muscles can also get irritated as well and cause contraction, which leads to bronchial hyperreaction. And as we talked earlier, we know that nasal polyps can form, and we know that it's usually a reduction of the TPA that usually causes a lot of the fibrins. And then with all the edema that usually occurs, that's how the nasal polyps occur in our patients. Oh. Come back. All right.
Ouch.
Okay.
We're still up. We're still up.
Oh no, he went big. Oh, sorry,
Okay,
Dr.
that's
Hoyt.
okay. That's okay.
All right,
I'll
how
go
you
big
feeling?
too. I'm feeling big. So let's do improving CRS with nasal polyp management for 600, please.
All right, team, let's go. Nasal polyp diagnosis requires the presence of bilateral endoscopically or radiographically visualized polyps in the middle meatus and, right chronic, persistent symptoms for a minimum of how many weeks? 1, more than 8. 2, more than 10. 3, more than 12. Or 4, more than 16 weeks. This is kind of a toughie, I think.
All right, great
It
job.
was a toughie,
yeah.
though. Yeah.
So the majority said the correct answer, which is greater than or equal to 12 weeks. And I will say it's a little hard not to give you a little wink, so that's why I don't make eye contact during the question. But let's do some talking about diagnostic criteria for CRS. So when we think about exactly, chronic is greater than or equal to 12 weeks, and this is a combination of greater than or equal to 2 symptoms of the following. So this is also confirmed by endoscopic or radiographic findings, as mentioned. So nasal obstruction, congestion, blockage, we know that's very characteristic of these patients. Anterior or posterior nasal drainage, so postnasal drip or anterior, and it's mucopurulent generally. Lost or decreased sense of smell, and with that, of course, comes the sense of taste, and then facial pressure, pain, and fullness. And generally, our patients complain of all of these, but at least 2 will get them the diagnosis. And then we think more about the uncontrolled or the severe patients. So uncontrolled patients are going to have persistent or recurring symptoms despite the regular use of intranasal corticosteroids, and they're receiving greater than or equal to 1 course of OCS, and or previous sinonasal surgery. So those are kind of the things that are telling us that symptoms are not well enough controlled. A course of OCS is thought to be 0.5 to 1 mg per kg per day for at least 5 days. And then the sinus surgery that kind of counts for this diagnosis is going to be any sort of procedure related to the sinuses, including resection of polyps. And then with severe, you think about, of course, the symptom scores, the nasal polyp scores, all of that kind of goes up. So bilateral polyposis is required, and then the nasal polyp score is greater than or equal to 4 on a scale from up to 8. And then the SNOT 22 score is greater than or equal to 35 points. Loss of smell score is greater than or equal to 2. And then the total system on the visual analog scale is greater than or equal to 5 out of 10. So these are really our most severe patients. In terms of making the diagnosis in the clinic, we think about, obviously, the physical exam, looking at the head and neck. As an allergist, not too much that we can see unless the polyp is gigantic and kind of coming down through the nose, but anterior rhinoscopy is definitely a start, and looking for mucosal edema. In terms of laboratory findings, you can get that through peripheral blood draw, but also through, with the help of your ENTs, tissue biopsies, and then there are some kind of more novel techniques looking at nasal secretions and nasally exhaled breath. And the importance of type 2 inflammation and trying to identify if a patient is type 2 high versus type 2 low is really important. So similar to our approach with asthma, we think about peripheral eosinophils and peripheral IgE, but then we also look at tissue eosinophilia, again with the help of our ENT colleagues. So greater than or equal to 10 cells per high power field. And then in terms of imaging, most of us will do a sinus CT scan. One way of quantifying this is the Lund-Mackay score that looks at how much pacification there is in the different sinuses and ranges from 0 to 2 for each area for a score ranging from 0 to 24 total, with 24 being the worst. And then sometimes there's a role as well for an MRI. And then in terms of procedures, so here's sort of where the money is, that nasal endoscopy that our ENTs can help with, visualizing the entire nasal cavity, looking at the meatises and the postnasal space, and really trying to get biopsies as well as cultures if you're concerned about an infection. And
oh yeah.
it's okay.
All right.
There's still time.
Yeah, so just to kind of help you remember that 12-week, when I was a resident, actually when you talked about sinusitis, there was acute sinusitis, which was 4 weeks. And, it kind of makes sense because, acute sinusitis, whether it be bacterial or viral, after 30 days, they usually self-resolve without even any medical treatment. And then there's this funny disease called subacute sinusitis. So it was from 4 weeks to 12 weeks. We never really knew what to do with that. And so we decided to get rid of it. So no one even talks about subacute sinusitis. And now we have chronic sinusitis, which is after 12 weeks. So hopefully that'll help you remember. All right.
All right,
so,
how are you feeling?
Since we're doing so well, Yellow Team is doing so well, I'm going to take $1,000 and let's get it from biologics for chronic sinusitis with nasal polyp.
All right, go big or go home. Here we go. Which of the following plays a key role in orchestrating the upstream activation of both type 2 high and type 2 low or non-type 2 inflammatory pathways in the upper and lower chronic inflammatory airway diseases?
Yeah. So
Number 1, TSLP. Number 2, interferon gamma. Number 3, interleukin 17. Or number 4, IgE.
Yeah, so I feel like we kind of...
Don't give them hints.
Okay, all right.
It's cheating, cheating.
We're just smart. Just listening. All right, 95%. All right, fantastic. Did someone applause? Yeah, absolutely, I agree. So TSLP, all right, so let's kind of go through that. And so here is the epithelial cytokine. So here are the epithelium, and as we talked about before, when the epithelium gets injured, they develop the 3 alarmins, TSLP, IL-33, and 25. And then the epithelium, whether it be through the alarmins or through the epithelium itself, can develop IL-4, which then differentiates the T cells into T helper cells, and then the ILC2, innate lymphoid cell 2, can also get activated as well. And then IL-5 specifically, we know targets the eosinophils, and then the IL-13 then causes the eosinophils to migrate into the tissues. Then we have IL-4, which then helps causes the B cells to become plasma cells to make IgE, and also affect the mast cells as well. And then IL-13, as we discussed earlier, affects the goblet cells and then also causes smooth muscle contractility. And so you see all this picture that we see, and this is this pathway is something that the allergist really did a great job in talking, and the pulmonologist as well did a great job in kind of differentiating how the airway inflammation kind of works. But I could say, a lot of the same pathway is same for chronic sinusitis with nasal polyps. So with that,
Aren't you getting really big, huh?
All right, green's coming back,
I
team.
think we might still be behind a little.
So, that put green ahead.
Nice.
Okay.
Well,
All right, so who's up?
let's see. So to use a phrase from my colleague, since we're doing so well, I think we'll go with 1,000 and alarmins in the upper airways.
Perfect. Let's see what we got. All right, although the majority of patients with nasal polyps exhibit type 2 inflammation, approximately blank have mixed or non-type 2 inflammatory components. Is that going to be 1/10 of them, 1/5, 1/3, or 1/2?
Okay, great. Yeah, that was a tough one, but most of you got it right. So the answer is 1/3. And so when we're answering this question, we have to think about endotyping patients. So when you talk about a patient having chronic rhinosinusitis with or without nasal polyps, you're really talking about their phenotype, but that doesn't give you a deeper understanding of what kind of inflammation is happening. And for that, you really need to look at endotype. And so thinking about endotypes can really help you guide that therapeutic decision making, because now you're targeting the right type of inflammation. And when we're thinking about CRS with nasal polyps or CRS without nasal polyps, we think about 3 different types of endotypes: type 1, type 2, and type 3. So we've talked already a lot about type 2, mediated mainly by ILC2 and Th2 cells, key cytokines IL4, 5, and 13, and the predominant cell type is eosinophilic. And the bottom box really relates to that type 2 inflammation, really kind of predisposing for worse outcomes. Type 1 is important. Also, it comes from ILC1 and Th1 mediated cells. And the key cytokine here is going to be interferon gamma, and the key cell type is neutrophilic. And then type 3 is going to be Th17 or ILC3 mediated. And there the key cytokine is IL17, and the key cell type is going to be the neutrophil. So thinking about kind of where our patients fall, if you look at all CRS on the left, and then CRS without nasal polyp in the middle, CRS with nasal polyp on the right, the top diagram looks at either patients who have just one type of inflammation or a mixed type of inflammation. So red is going to be those patients who just have type 2 inflammation. And of course, that's the biggest in this country in all the categories, even more so with nasal polyps than without, but really predominates all of the graphs. But you see that the purple, the light green, the orange, the blue, those are all, I think it's black actually, the black are all mixed inflammation. And so you kind of get a sense that a lot of patients have more than one type of inflammation, and that makes the type 1 and type 3 inflammation very relevant. And then the tan color is going to be the untypable. And then if you look at the bottom panel, that is just showing patients who have any component of type 1 versus any component of type 2 versus any component of type 3. And you can see again the type 2 predominates, but about 1/3 of patients have either type 1 or type 3 in the mix. And that's where the answer comes from for our question. So really targeting those inflammations is going to be important as well.
Oh, yay! All right.
It's okay.
Yeah,
We got
comeback.
this.
All right.
He's back. All right.
All right. Great job, Yellow.
What's our total right now? Oh, he pulled
Oh,
ahead.
oh
We've got
yeah.
time.
All right.
We've got time.
So what do you need?
All right. Since I treat a lot of, I'm an old ENT, I like to do maybe 800 for improving chronic sinusitis with nasal polyp management.
Let's see what we got. Okay. Which of the following sets of first-line therapies have substantial evidence for improved quality of life and reduced sinonasal symptoms for patients with nasal polyps? 1, nasal saline spray and intranasal corticosteroids. 2, nasal saline irrigation and intranasal corticosteroids. 3, intranasal corticosteroids and macrolide antibiotics. Or 4, macrolide antibiotics with nasal saline irrigation.
Oh, so if you read the iCard doc,
Hey, cheated again. Shush.
I'm just saying, I'm not
Let
giving
him
the answer.
think about it.
Oh, see, I knew you guys got it right because you guys read the iCard document, the 758-page iCard document, and what says exactly what you guys said. Nasal irrigation and intracortical steroid is the first-line treatment for chronic sinusitis with nasal polyp. And when we look at the evidence, we know that people with chronic nasal polyps have inflammation that you see the thick eosinophilic mucin in the nasal cavity. When you do the nasal rinses, it kind of washes those away and decreases the inflammation. Another way of doing it is using intracortical steroid spray. And so there's one specifically that has been specifically approved for a nasal polyp. And so those also decrease the inflammation associated with nasal polyps. Antibiotics, on the other hand, not so much strong evidence for use of chronic sinusitis with nasal polyp. Now, the only time I actually use antibiotics is so that I can get a CT scan for a patient with nasal polyp, because a lot of our insurance in Virginia often requires a 3-week course of antibiotics. So I reluctantly give it so I can get the CT scan. Macrolides, it does work, but it really targets IL-6 and IL-8, and so not so much the type 2, which is mostly nasal polyp. And the macrolides do work, but not as strong. And then in terms of oral corticosteroids, definitely it works, right? But the problem with that is that there's a lot of adverse effects associated with that. And so for nasal polyp, it works really well, but for CRS without nasal polyp, not so much. And the problem with using systemic steroids is it causes a lot of adverse effects. So these are all the different adverse effects that's associated with systemic steroids. And in fact, the question that a lot of the expert rhinologists have been asking is how much is too much, right? How much systemic steroids can you give? And so we've actually taken a lot of data from the asthma data, and we say anything more than 400 or 500 in a year is too much. And so how much is 400 or 500 milligrams of prednisone in a year? That's only 2 courses of systemic steroids. So if you give a patient 2 courses of systemic steroids in a year, that's over 500 or around 500 a year, and that's way too much. Oh, no, oh, no. I can't believe it.
I like it.
Oh, no.
Good. All right, well, now that you're on a roll, how are you feeling? Let's see. Ooh, we're tied.
Oh.
Okay.
Okay.
Let's do the unified airway model for 600.
All right. Unified airway, 600. The presence of nasal polyps in a patient with CRS blanks the risk of revisional interventions within the blank years after treatment with initial FES. 1 doubles within the first year, 2 doubles within the first 5 years, 3 triples within the first year, or 4 triples within the first 5 years.
Question even for me.
Yeah, this is tricky.
Yeah.
Definitely a tough question. Once again, though, the majority is correct. So the presence of nasal polyps doubles the risk of revisional intervention, so not necessarily surgery, but interventions within the first year after treatment with initial FESS. And so that information really is on the right in the green box there. And we know that nasal polyps, again, makes things worse for patients with CRS. So not only does it double the risk of revisional interventions within the first year, but it also elevates cost of care, increases hospitalizations and emergency room visits. Part of this is that comorbid asthma and the worsening asthma that happens when patients have CRS with nasal polyps. But more importantly, what we hear in the clinic is really the effect on quality of life, right? These patients are miserable. They have obstruction, congestion, all the other symptoms we were talking about, and that really does impact quality of life tremendously. And as many as half of patients are affected on a daily basis with these symptoms. And that is in addition to the symptoms that Dr. Han just mentioned related to the corticosteroid bursts. So while they're on the corticosteroids, they feel bad. And then, of course, they're stacking up these different side effects that over time catch up with them. So really an unmet need there is trying to make these patients feel more comfortable on a regular basis and then trying to minimize these long-term complications. And With that, good job, team.
Well
we take the
done.
lead.
All right.
Oh, come on, Yellow.
All right, all
Come
right.
on, Yellow. We could do it.
Okay,
right.
so how are you feeling, Ben? Oh, she's like,
I know.
that's a big lead, bud.
I know.
Sorry.
Okay, I'm going to be a little timid now. So let's go with maybe 200 for improving chronic sinusitis with nasal polyp.
Okay, let's see what we got. What percentage of patients experience nasal polyp recurrence within 18 months of surgery? This is on average. Don't take offense if you're a surgeon in the office. I'm sure you're better than the average, but still. 1, 20%, 2, 40%, 3, 60%, or 4, 80%. Of course, I mean, clearly, as expected.
All right, so people said 60%. And you know, that's not too far off, but I think 40% is the number. And this is from the Adam DeCon's paper where he looked at a group of tertiary rhinologists and did surgery plus medical treatment afterwards. And this is before the era of biologics. So this was published in 2017. And so I'm wondering if in the era of biologic, maybe the number would be a little bit lower. And so here's that paper. And so what they did was they looked at patients with chronic sinusitis with nasal polyp from several academic rhinology centers, and they did surgery. And so one of the questions is, you know, if you do surgery, do you do appropriate and a thorough surgery for patients? Because not all sinus surgery is the same. And so then after that, then we know that it's a chronic disease. So you expect the polyps to come back, but you're hoping that they won't come back with medical treatment. So they gave good medical treatment afterwards. And even with that, you could see that the percentage of polyps started coming up and up and up, as well as edema goes up as well. And so this kind of is consistent with what we talk about with chronic sinusitis with nasal polyp being a chronic disease. And it's, you know, it's not, you know, there's this concept that, among patients that if you do surgery, that the polyps will go away and they'll never come back. But that's not true. And so those are one of the things that we try to set expectations for the patients. So the question is, you know, are there ways to predict? You know, what are the factors that you can use to tell a patient, hey, what's the likelihood of the polyps coming back? And so one is if you have a high SNOT 22 score or a patient-reported outcome measure. If you have a high one, then these are usually not going to be very high. You know, if you have loss of smell, again, it means that usually a polyp in the olfactory groove, not a good predictor. But if you want to predict whether or not the patient can get their sense of smell back, we give them a short burst of steroids, and if they can get their sense of smell back, we tell them by doing surgery and getting rid of the polyp, we can get your sense of smell back. So it's not that the steroid is the magic pill. What the steroid is doing is trying to get rid of the inflammation and seeing if it's reversible. Because with multiple sinus surgery, you can eventually lose your sense of smell. And with chronic nasal polyp, that irritation can make you lose your sense of smell forever. And so certainly people who've had one sinus surgery overall tend to do better. People with asthma and ARD tend to do worse. We see that people with neutrophilic and biofilm tend to do worse. And then again, you know, if the patients are compliant with the post-operative medical treatment afterwards, they'll also do better as well. Ooh, yes. So, all right.
All right.
There's a small number, but all right, let's see.
Maybe you guys are like getting back on your track, though.
All right, all right.
Okay.
So getting closer, all right.
All right. Dr. Hoyt, how are we feeling?
I'm feeling good. I think we should do one of the 800s, and let's do biologics for CRS with nasal polyps.
Ooh, all right.
Daily double, all right.
So daily double means whatever team gets this, the team gets double the 800.
Yellow.
You get 1,600 points.
I see
So whoever gets
there.
this for sure is pulling ahead. Okay.
Come on, you know your biologics.
Let's go, teams. So which of the following were used as endpoints in the Polyp 1 and Polyp 2 clinical trials? Guys ready? 1, your options are nasal polyp score with nasal obstruction score. 2, nasal congestion score with nasal polyp score. 3, nasal congestion score with SNOT 22 score. for nasal polyp score with SNOT-22 score? It's a tough one.
Okay, yeah, and it's not the daily double for nothing. That was a tough one. So the answer is actually 2, which is nasal congestion score and nasal polyp score, although SNOT-22 score was one of the secondary endpoints and was looked at in all these studies. And we'll kind of go through all the different clinical trials. So first, let me tell you the 3 approved medications by the FDA for treating both asthma and chronic rhinosinusitis with nasal polyps are dupilumab, which targets IL-4 receptor alpha, thereby blocking the IL-4 and IL-13 mediated inflammation. We know that dupilumab is approved in moderate to severe asthma, either eosinophilic phenotype or OCS dependent, and it's approved down to age 6. In chronic sinus disease with nasal polyps, it's approved down to age 12. And obviously it has other indications too with EoE and atopic dermatitis, prurigo nodularis. For mepolizumab, which blocks IL-5, it is approved for severe asthma with an eosinophilic phenotype specifically, and that's down to age 6 as well. But in CRS with nasal polyp, it is down to age 18. And as we know, mepolizumab is also approved for EGPA and HES in higher doses. And then omalizumab, which blocks IgE, is approved for moderate to severe allergic asthma that's inadequately controlled with an ICS. And that is down to age 6. We also know that it is approved for CIU and now more recently food allergy. But in CRS with nasal polyps, it is approved down to age 18. So let's talk about the data that kind of got approval for these different medicines. So omalizumab is the medication that was looked at in the POLYP 1 and POLYP 2 trials. And you can see those 2 primary endpoints are going to be the nasal polyp score and the nasal congestion score shown here. And so what you're looking at is POLYP 1 and POLYP 2 were 2 parallel randomized placebo-controlled trials. And so the POLYP 1 placebo is going to be in blue, and then the POLYP 1 treatment arm is going to be in red. And then for POLYP 2 study is in green and yellow respectively. And so you can see on the left for the nasal polyp score, there was a very rapid decrease in the omalizumab group for both arms of the study. And then also for nasal congestion, same thing, and it was sustained throughout this 24-week trial. The primary endpoint was at 24 weeks, and then they had some secondary efficacy analysis at 16 weeks. Moving on to dupilumab. So dupilumab had 2 different studies, the Sinus 24 and Sinus 52 trials. Sinus 24 is shown on the top and Sinus 52 on the bottom. Same primary endpoint, so nasal polyp score and then the nasal congestion or obstruction score. Sinus 24 was a 24-week trial with dupilumab, 300 milligrams every 2 weeks. And then at the 24th week, the dupilumab was taken away and patients were continued to be observed until the 48th week. And then in Sinus 52, patients were given either 300 milligrams every 2 weeks for the full 52 weeks, or they were given every 2 weeks for the first 24 weeks, and then at the 24-week mark, it was changed every 4 weeks, and that was continued to 52 weeks. So you can see at the top the Sinus 24 data, again, very rapid decrease in nasal polyp score, as well as nasal congestion or obstruction. And that was sustained through 24 weeks, and then when the dupilumab was taken away, the score started going back up and aligning more with the placebo arm. So suggesting that this medication helps is disease controlling, but not necessarily disease modifying long term. And then looking at Sinus 52, you can see that dupilumab every 2 weeks versus the ones who got every 2 weeks to 24 weeks, and then every 4 weeks thereafter actually did both pretty much just the same, much better than the placebo arm. Again, a rapid decrease that was sustained through the end of the study. And in all of these studies, we're looking at really the more severe patients who have inadequate control despite continuing their intranasal corticosteroids, and they've had oral steroids and or sinus surgery leading up to the trial. And then lastly, with mepolizumab, this is the SYNAPSE trial. So over 400 patients looking at nasal polyp score and nasal obstruction score as the 2 primary outcomes. And you can see by week, you're looking at the patients with greater than or equal to 1 point improvement in the total endoscopic nasal polyp score. And this graph is looking at rate ratio. So the odds ratio, was 2.74 by the end of the trial in the nasal polyp score. And then for nasal obstruction score, you're looking at the visual analog scale, and there was a decrease in about 3.5, I believe, in the mepolizumab arm compared to placebo. So again, a rapid decrease that was sustained throughout the trial. And then just thinking again about those ongoing disease burden and unmet needs. So we talked about the symptoms that our patients are having, both with chronic sinusitis with or without nasal polyps, as well as with allergic rhinitis in our most severe allergy patients. Fatigue, mood changes, impaired cognitive function, depression, anxiety. So a lot of morbidity, even if not mortality. And then a substantial portion of patients with asthma continue to have worsening asthma because of this unified airway. So high level of medical and mental distress, decreased productivity due to missing work and school, and then increased risk for death with the more severe asthma. And then importantly, you can see in the red box, there's still no FDA-approved biologic to treat allergic rhinitis, and there's none that is specifically indicated in non-type 2 CRS or asthma. And with that,
yeah, that's a big win. That was a really big win. All right. Hey, and just to kind of help you remember, about the primary endpoints that were done in the study. So when we were creating these clinical study protocols for biologics and nasal polyp, we've had a lot of conversations. So FDA, the regulatory agency definitely said, okay, nasal polyp score easy. Okay, so, but we know that sometimes the sometimes the objective measure doesn't always correlate to symptom measure. So we actually had an hour-and-a-half conversation about, which PRO, which symptom do we want to measure? And, we all agreed that loss of smell probably is the best measure for seeing if the nasal polyp is there or not. But the problem with that is that sometimes is not irreversible. Right. And so after a lot of conversation and having a lot of conversation, we decided to say, okay, let's do nasal congestion. Now, I want to let you know there is a difference between nasal obstruction versus nasal congestion. It's subtle, but I'm going to take the big win and sit down. All right.
All right, wait, no, don't sit down. I think you're up.
All right,
you're up.
all right,
What do you want? Now you're on your street.
Okay.
What do you want?
All right, let's go to the next one. All right, I'm feeling pretty good, right? Yellow had a big win, and so let's do 800 for unified airway model.
All right, okay, let's see what you can do it. According to the EPOS Euphoria consensus definitions for nasal polyp treatment goals, remission is defined as no symptoms or endoscopic signs of active disease for how many months? More than 6, more than 12, more than 18, or more than 24?
Oh, you guys are really good. You guys must have read that paper because, so let's talk about that paper. So there were a group of doctors, allergists, pulmonologists, and rhinologists. We all got together and we said, now that we understand that chronic sinusitis with nasal polyp is a chronic disease, why aren't we using terms that kind of relate to chronic disease, such as control, remission? And no one really talked about cure, but a group of us said, okay, let's be a little bit ambitious and let's maybe talk about cure. And these are terms that we use in rheumatoid arthritis. These are terms that we use in asthma. And so, what was easy was, okay, control, right? So we said, control, let's just target for symptom relief. And just do it for a month. And if they can control their symptoms and they feel pretty good, we said that's control for a month. But then after that, let's talk about remission. And then how long do we want it to be? And, similar to that of asthma, we said maybe a year. And then one of the questions that came up is during this remission, do you talk about remission with medicine or off medicine? So, are they in remission even if they're on medicine, or do they have to be off all medicines? And so there was a big conversation about this, and at the end there was a consensus that, not 100% agreement, but definitely a majority of people said, okay, we should talk about remission while on medication. And the only medication that you can't be on is steroids. And that's what we see for rheumatoid arthritis and for asthma as well, and that's consistent with nasal polyp. And I think before the era of, well, okay, I'll stop there. And then we said, well, what about cure? So if we can control their symptoms, and there's no evidence of nasal polyps, and they have to be off medicine by year 5, can we call a cure? And we know that's really ambitious, and we'll see how it goes. But so far, a lot of people, we haven't gotten a lot of negative feedback for that, and so we'll see.
All right. So we're going to sort of pause and have a little chit chat up here, because so sustained remission and cure are things that, like, do we as a team, do we as a field right now think that this is actually realistic for most patients with nasal polyps? And I would argue that we should probably divide that into like realistic today with the tools that we have now versus realistic on the horizon in the next decade or so. So you each get 30 seconds to give me your opinion. Dr. Hoyt, do you actually think that this is truly achievable or realistic for patients with nasal polyps?
Yeah, so I think it is achievable for some. It's not achievable for all. So we've talked about type 2 inflammation and non-type 2 inflammation. And obviously the non-type 2 inflammation, I don't think it's achievable right now. We definitely need some more targeted therapy for those kinds of patients. Mm-hmm. For the type 2 inflammation, again, it's not going to be achievable for everybody, but it's similar to asthma where there's a percentage. And we see this in clinic where now with, maybe they've had a surgery or two, but now with the biologics, we're seeing that these patients are going into sustained remission. It's on treatment. I'm not talking about cure, but I do think it's possible with biologics for some patients.
Yeah, and I'm an optimist, and if you haven't figured that out already. So my answer is simply yes. So, before the era of biologic, I would have said that, even as an optimist, I would have said no. I mean, it's impossible. We struggle with them. There's this urban myth that ENT doctors like to operate and operate again so we can make money. That's a lie. We don't. I mean, we only want to operate once and get the patient better and done. Now, if somebody else does a surgery and they come and see you, well, that's a different story. But for you, if you do it, you just want to do it once and never have to do it again. And so before the era of biologic, this new class of drugs for nasal polyp, I would have said it's impossible because, I just tell patients, especially ARD patients, every 3 to 5 years, just assume you're going to have surgery again and again. But now with the era of biologic, I mean, that's not a conversation I'm having anymore. So I do think that it's definitely possible to have remission, especially with medication.
Good. I like the optimism. I think we're both pretty optimistic. All right, good. All right, so, sorry, we came back from that one. All right, we got the 800. I totally missed that. All right, we're winning. We got it. All right.
We're catching up.
This is tight. This is tight, team. All right, I think we're up to Dr. Hoyt was next.
All right, I'm feeling good.
What do you like?
Let's do 1,000.
And
okay. Let's do unified airway model.
All right. Excellent. Let's see what we got. So, according to the 2024 EPOS Euphoria publication, which of the following criteria is used to define the response to biologics in nasal polyps? 1, improved nasal drainage. 2, improved sense of taste. 3, reduced need for intranasal corticosteroids. And 4, reduced need for oral corticosteroids.
Okay, good work, team. So they're all going to improve, but really what we care most about is going to be the reduced need for OCS. And so I have that criteria here for you. So the defining response to biologic treatment, there are 5 criteria that are evaluated. The first is reduced nasal polyp size. The second is reduced need for OCS or salvage surgery. The third is improved quality of life, again, using a PRO, in this case, SNOT-22, getting the SNOT-22 less than 40, or showing a minimal clinically important difference, and decreasing the score by greater than that. Improving sense of smell, so that was a trick question because taste and smell go together, but it's smell that we care about, hyposmic by semi-objective smell test. And then a reduced impact of comorbidities, which again is defined by that MCID for whatever specific T2 disease we're talking about. And so defining a good or excellent clinical response is going to be if you meet 4 to 5 of those criteria, Moderate is 2 to 3 of those criteria, and no or poor response is 0 to 1 criteria. And the important thing here is going to be to reevaluate and constantly kind of go back to that patient and make sure that they're doing well. And if not, is it time to switch? Is it time to think about something else? Or is it time to go back to surgery? So the first evaluation should be at 6 months. If all's well, you just keep them on the same biologic and reevaluate at 12 months. And then if you're meeting only 2 to 3 criteria or less, then it's time again to think about the diagnosis. Am I missing something? Is there a complicating factor? And what should we do to get things better? So with that.
Oh.
Yeah, all right.
All
All right. So great job, yellow.
Okay.
Yay,
Yellow
yellow.
team, we got it. That's right.
All
You guys are back. You guys are back. All right.
Ooh,
that was a big
we're
pull
up.
ahead.
No, that was a big one.
That was a big risk.
You guys
It
are
was a
going to
big
catch
risk.
up. All right.
All right, what are you thinking?
Ooh, there's not a lot to choose from, but let's go with 400 for improving cross-size nasal polyp.
All right. Oh.
What? What is that?
Oh, you lose.
What?
You don't even get to ask a question. You just lose $400.
You never even talked
sound
about
It
it.
wasn't in the instructions. That was a trick.
like,
Sorry, guys. So, yellow team just lost $400 by doing nothing. Sorry.
Oh, no.
Sorry. Oh, you just lost your $400.
No.
Go green.
Oh, horrible.
All right. In which case, I guess we're moving forward then. All right. Well, you get to go, Dr. Hoyt. What are you
Okay,
thinking?
So we'll do the 800.
Okay.
800 for alarmins.
Yep. All right. Let's go. Fibrin deposition. All right, new topic. Cross-linking are believed to play a role in nasal polyp formation under the influence of which of the following cytokines, which are under the influence of the epithelial-derived alarmins? IL-1, IL-4, IL-5, or IL-13?
All right, good work. That was a tough one, but you are correct. It's IL-13. And I noticed that when Dr. Hahn showed this earlier, he talked about all the different roles of IL-13, but did not talk about fibrin deposition and cross-linking. So I think that was on purpose to leave some room for growth here. So you can see the epithelium's up above, all the different cytokines they trigger. I'm going to focus on IL-13. And we talked previously about the goblet cell hyperplasia, the mucus production, smooth muscle contractility. Now if you look at the purple boxes, there's M2 macrophage polarization, fibrin deposition, which then comes with cross-linking, and you form a nasal polyp. And so I'll show you how that happens in just a moment here. So in the upper left corner, you see the normal mucosa. You've got a mucosal barrier. You have a mucus layer up above. You have some little microbes that are, healthy colonization. And then you've got the submucosal glands. And then as you start getting chronic rhinosinusitis, you start losing that barrier. And then the microbial content is going to be less diversified, and there's going to be more of it. And because there's not as good of a barrier, it's coming inside through the epithelium. And now you're going to get a lot of inflammation. Inflammatory cells are recruited, and that's when the IL-13 becomes relevant. Fibrin is deposited, cross-linked, and now you see that fibrin moving up into that outpouching on the bottom right rather, and that's your nasal polyp. So you see the fibrin cross-linking. You see a lot of inflammatory cells. Impaired barrier, again, that non-diversified microbial inflammation. And so and loss of submucosal glands as well. So with that, yes, good work, team.
All right.
And that was a big one.
That was lucky. That was lucky. Green's coming back. All right. So, that brought it close. Okay, team. All right, Dr. Hahn.
Okay, all right. Well, that's awfully close. So let's pick a low number. Let's do 200 for biologics for nasal polyp.
All right, here we go. Which of the following might be considered as a contraindication to repeat sinus surgery in a patient with nasal polyps? 1, septal deviation. 2, recurrence of nasal polyps more than 3 years after the prior surgery. 3, the patient is physically very fit. Or 4, a CSF leak after previous surgery.
All right, the audience is right. And so, I would say in general, if someone has a CSF leak, the reason why we try not to do revision sinus surgery is that there's a skull-based defect, and then there's usually brain matter that usually goes into the ethmoid cavities, and because of that, we try not to. But with that said, with the technology getting better, I think we can actually even do surgery, even with the CSF leak as a prior surgery. Now, one of the questions that comes up is if you have chronic sinusitis with nasal polyp, as before the era of biologic, as I said, a lot of people have to do recurrent sinus surgery. And so one of the things that we want to do is, figure out, what can we do to try to make it better? And so, certainly want to do a good initial surgery. And if they do a good initial surgery, then we're happy, and then we could do medical treatment. If the initial surgery was something like minimally invasive, or maybe like a balloon, especially for nasal polyp, I would say then doing sinus surgery is helpful, because what you want to do is you want to do these big open surgeries to try to prevent the polyps from coming back. And like I said, if they are adequately done, certainly you want to think about medical treatment like biologics. And I think patients with asthma tend to have the polyps come back, and so I think that's kind of where in the era of biologic, it really brought a lot of specialists together. And so in our community, we have pulmonologists, allergists, ENT, and now rheumatologists involved when we're talking about using biologics for patients with nasal polyp, because some of these patients have been on biologics for their rheumatoid arthritis. So if they're getting a biologic for a TNF or CD20, how does that interact together? And we really don't know the answer, but that's why we always have these multidisciplinary approach to talk about, if we're going to give a biologic, which one should we pick? And certainly, I think a shared decision-making process is important, and we talk to patients, and what we want to do is make sure that they heal well after the surgery and that there's no scar tissue, because if they are, you're more likely to do surgery. And then if they're, if everything looks good, if they have severe systemic inflammation, certainly a biologic is a better treatment option for those patients.
Good work. She took it.
I think
She
it's
took it.
tough.
All right,
no.
Green.
All right.
All right.
It's a
Oh.
Okay.
Okay. This
All right.
is okay. All right.
All
Okay,
right,
we can do
let's
it.
see.
We can do it, guys. Stay strong. What do you want?
All
How are you
right.
feeling?
We're gonna go big.
Oh.
So let's do 1,000 in the only 1,000 left, improving
okay.
CRS with
There we
management.
go. All right. According to the EPOS-FORIA criteria for biologic treatment, in nasal polyps, use of low-dose oral corticosteroids for blank number of months is considered long-term. More than 1, more than 3, more than 6, or more than 12 months.
Shutterstock Music.
Okay, yeah, this was a tough one. Our answers are kind of all over the place, but the answer is greater than 3 months, and I'll show you the criteria here. So in patients who have had surgery, are they a candidate for biologic treatment? Again, this is with the current biologic treatments that we have, which are mostly targeting that type 2 inflammation. And so you need 3 criteria, again, just based on the guidelines. We all use clinical judgment in the clinic, but, and one of the criteria is going to be evidence of that T2 inflammation, right? We have medications that can target T2 inflammation, so make sure it's actually the right endotype. Beyond that, we think about oral corticosteroids, and so here they define it as greater than or equal to 2 courses per year, or a long-term, which is greater than 3 months of low-dose OCS. And so either the need for that or contraindication to OCS is another criteria that would help push towards a biologic. And then the others more have to do with quality of life and impact of disease. So if they have significantly impaired quality of life, significant loss of smell, and then of course the diagnosis of comorbid asthma, because that comes with it a lot of extra morbidity. So, good work, team. That was 1,000.
All right. Okay. All right.
Okay.
I feel like maybe I should be on Team Green. I feel like that might be the winning
All
team.
right.
Ooh.
Okay. All right.
Okay.
Not a lot left to.
Yeah.
I thought we were going
You
to
got
win.
You got some slim pickings.
Yeah.
What do you want in there?
After the double Jeopardy, I thought we were going to win. All right. All right. Okay. I got to go big. All right. Let's go 600.
All right.
For
biologics,
for
that's
nasal
your
polyp.
only option. Ooh.
Ooh.
Wait. I think
All
free
right.
parking means that everybody gets $600.
All right.
What?
Oh, okay.
No.
Oh, everybody just gets more money.
Oh, no.
Okay, there you go. It's
No,
like a
that
double
doesn't
win.
help.
It's a
Oh,
double win.
Great
that feels
choice.
that feels like a double whammy again. Oh, man. All right.
All right, all right.
So I'm not great at math,
But
but
I think you only have one choice, my friend. Okay.
okay.
She's gonna go for.
We'll do 400 for biologics.
All right. Okay, final question. Guys, come on, we can do this. Okay. Which of the following phase 3 clinical trials is evaluating the role of a biologic therapy that blocks TSLP for the treatment of patients with nasal polyps? 1, Anchor 1, 2, Orchid, 3, Waypoint, or 4, Contrast nasal polyp?
Stop music.
Trial names.
Good work. So this was another tough one because you know what the trial's looking at and what it shows and how it impacts your patient, but you don't always know the name of the trial. But you are correct. It is Waypoint, or most of you are correct. So these are the different medications, biologics that are currently in phase 3 trials, and I'll talk a little bit about each one of them. So first starting off with tezepelumab, which blocks TSLP. So we've talked a lot about TSLP today. And so you can see by blocking TSLP, you're going to block all of the downstream effects of TSLP. So that allergic inflammation, the eosinophilic inflammation, and even to a certain extent, the neutrophilic inflammation. So the studies looking at tezepelumab, currently there's a phase 3 Waypoint study, which was what the question was about. Co-primary endpoints are change in baseline total nasal polyp score, and then also the nasal congestion score. And this is at week 52, so it's a 52-week trial. We do have a little bit of data that suggests that this will be a promising drug in our patients with CRS and nasal polyps. And this was actually published by Dr. Laidlaw and her team, looking at a post hoc analysis of patients from the asthma trials. So looking at tezepelumab and asthma, of course, there's going to be a subset of patients with CRS with nasal polyps. So looking at those patients and how they did, and the SNOT-22 total score did improve as compared with placebo, and that improvement was sustained over 52 weeks. Benralizumab, so a phase 3 trial called AUSTRO, was actually performed, and it met the co-primary endpoints of a nasal polyp score and nasal blockage score, NBS.
Yeah.
So the two primary endpoints were met, but the two secondary endpoints were not, and so the FDA said, issued this CRL asking for more data, and more data is now coming with this ORCID study, which is a phase 3 trial looking at benralizumab. Again, same primary endpoints, but gathering more data for more patients, and so that study I think is going to finish by the end of the year or next year. So we will see what that shows. And benralizumab blocks IL-5 receptor alpha. In terms of other late-stage investigational biologic therapies, we have CM310, which is another anti-IL-4 receptor alpha, so similar mechanism to dupilumab. There was a phase 2 trial called the CROWNS-1 study, which had promising data to week 16, and now there is a phase 3 trial called CROWNS-2, which is looking to week 24, and the same primary endpoints of NPS and CS. And then depemokimab, which is another anti-IL-5 receptor. This is a promising drug in the sense that it's dosed twice a year, so longer acting. And the phase 3 trial is called Anchor 2. And again, looking at nasal polyp score and nasal obstruction score, and using the verbal response scale, so week 49 to 52, so a little bit of a longer study.
Oh.
And with that, yellow wins.
Uh-oh, but still,
not enough.
wait a minute. Math?
Is it enough? I don't think so.
No, go ahead.
That's okay.
All right.
Great, Tom. Great job, yellow.
Fully dedicated to green. That was a strong win. There was a strong pull ahead in the end. It was good. All right. Yes. Yeah, we're good. We're good. All right. So we've covered the board. We've learned everything there is to learn. Overall, right? We can all go home with the green pom-poms.
But it was really close.
No, it wasn't that. You have to be. You're not that close. It wasn't that close. At the end,
Okay,
you guys
fine.
crushed it. All right, so we're going to sort of finish up with kind of what we learned here and then go through the post-test questions. So, overall, the general theme was that the upper and lower airway, we talked mostly about nasal polyposis and asthma. Those are closely related, and they frequently coexist. They're comorbid at the same patients. And patients who have the unfortunate situation of having the comorbid upper and lower, right, polyps and asthma, tend to have overall more disease both in the upper and the lower airways. And they just, frankly, tend to be harder to treat for both their upper and lower airways. Now, in the top right, you're going to see that biologic therapy in many ways, in many targets, has in fact demonstrated efficacy and safety for the treatment of nasal polyps and in the treatment of patients with asthma. And I think makes a lot of sense in those comorbid patients particularly, and really does show the improvement in patient outcomes for sure. And I think, as might be demonstrated by the choice of the folks up here, like a multidisciplinary team, especially for these comorbid patients, can make a huge difference to the care of these patients, to their evaluation, to their treatment, and to their treatment options. And so for sure, allergists, immunologists, rhinologists, pulmonologists are critical to kind of caring and getting out into the community and getting kind of like, get your person, right? Get your person that you refer back and forth to that you guys feel comfortable working with. It can make a huge difference to evaluation and treatment of these patients. All right, so memories. Let's go. We're going to go pretty quickly through these, and we're not going to necessarily see who got them right or who got them wrong, so you can keep your secrets about what you did or did not get right. But airway. Which of the following cell types produces alarmins in response to triggers, like allergens, microbes, and irritants? NK cells, epithelial cells, innate lymphoid cells, or T helper cells? All right, we're just gonna, ooh, yeah, go team. All right, 89% got it right. Well done. Okay. What percentage of patients experience nasal polyp recurrence within 18 months of surgery? 20%, 40%, 60%, 80%. Ooh, okay, again, crushing it. All right, 93%, this is great. Correct answer, okay. Which of the following plays a key role in orchestrating upstream activation of type 2 high and type 2 low inflammatory disease in upper and lower airway? TSLP, interferon gamma, IL-17, or IgE? Ooh, wow, okay. Well, I mean, you can't get better than an A+. Well done, well done. A lot has been learned. Good. Oops, am I wrong? According to the 2024 EPOS Euphoria publication, which of the following is the criterion to use to define a response to biologic treatment? Improved nasal drainage, improved sense of taste, reduced need for intranasal corticosteroids, or reduced need for oral corticosteroids? All right, excellent. Yeah, reduced need for oral corticosteroids. We are learning. Good. Which of the following phase 3 trials is evaluating the role of the biologic that blocks TSLP? 1, Anchor 1, 2, Orchid 3, Waypoint 4, Contrast MP. Also 100%. You guys were so smart. Good. You learned a lot. I love it. How often will you now recommend biologic therapy for patients with uncontrolled nasal polyps? 1, never. 2, quarter of the time. 3, 50%. 4, 75. 5, all of the time. Or 6, I still don't manage any patients, so I'm just here to learn some stuff. All right, fine. Everybody had their own space. That's fine. There's no right answer here. Is that the last one? Okay. All right, so we have a couple minutes left, and we have some audience questions that we're going to go through. We can discuss each of them, but I sort of handed ones that I thought were like most relevant to each person's expertise. So we have one about when to kind of either stop biologics after you've gotten better and return to sense of smell and remission of symptoms for more than a year, or when to kind of space the dosing of biologics. So I'll start off and I'll see what you guys do. I usually, so Okay, I guess it depends on why I'm starting the biologic. So if I'm starting a biologic on a patient who has both asthma and nasal polyps, because that's the sort of easier thing, I think determining success of a biologic for a patient with bad polyps is actually easier than determining success for a patient for severe asthma. Because for some of our asthma patients, they get exacerbations, but maybe their day-to-day function is okay. And then I'm just waiting a whole year to decide, did you have one fewer exacerbation this year than you did last year? That's really hard. So that's a hard place to then decide if I'm gonna space anything out. In general, if I'm treating primarily for asthma, I do not space the biologic out. What you get, whatever the FDA said and the study said, that's what you're gonna do. For nasal polyps, I think, like as you saw in the studies, you can get some pretty quick responses in a lot of these biologics. And so I will usually do a 3-month check-in and just to make sure everything's going okay, and then a 6-month check-in, and we decide at that moment, right? At 6 months, either patient and doctor are happy enough that we have decided to stick with this biologic, and then we kind of ask whether or not we want to stay at the same dosing or you want to change the frequency to being less frequent. And the question that I ask every patient is that on the biologic that you're on the frequency that you have to get it, is it every 2 weeks, is it once a month, is it every 3 months, depending on your biologic, right? On the day or the week before you're due for your next dose, are you just taking it because you remember because the calendar said so and you're a good patient, you do what the calendar says? Or do you kind of know that you need it, right? Are you like, ooh, I wish I could almost get it earlier. I still need my biologic at its prescribed time. And if the patient says, oh, I can't even tell, I just do it because I'm a good person, you told me to take it every 2 weeks or every 3 months and I do what I'm told, then I say, okay, let's try to space it out until you feel like you need it, and then that's gonna be our frequency. As opposed to the patients who say, ooh, yeah, I actually wish I could take it more frequently. And I don't suggest that they space it out at all. And in terms of stopping biologics after return to symptoms of smell or after remission of symptoms for a year, I don't stop biologics. There's no evidence so far from the studies that we've seen that any of them are curative in the sense that you can completely stop. But I will absolutely encourage patients to space out the frequency if they're doing well. It seems like less drug is better, and they can usually tell within a couple months, ooh, this is not as good as it was. We'll go back to the prior frequency, or I feel fine with less drug. Would you guys answer that differently?
No, I do exactly the same thing, with the only caveat being obviously side effects.
For sure, yeah. Yes, this is no negative side effects, yeah.
So actually, I will answer a little bit differently. And part of it is, I think you're right. Biologic and asthma is much harder to do what we would call step-down therapy, right? Trying to figure out, can you start weaning them off the biologic? But for nasal polyps, it's a little easier because you can do nasal endoscopy, you can do we have a lot of good patient-reported outcome measures. And so we can kind of see how they're doing. And because of that, and the other thing that we could do is do topical steroids. And a lot of the patients who are initially on biologic feel so good, they stop the topical steroids, whether it be spray or other ways of delivering topical steroids, and then all of a sudden they get a little bit worse and they're kind of wondering why they got worse. Well, they got worse because they stopped the topical steroids. So I tell them to go back on it and they do well. And as long as they're doing well and they're on the topical steroids, we see that the patients are organically increasing the interval between them. And there's actually a really nice study from the Netherlands that showed that if you could increase the interval between a biologic after 6 months or after a year, you could still have control of their symptoms and the nasal endoscopic findings. And I think, and we've had biologics long enough where we've had patients on it for 3 or 4 years now. So we've been able to get a couple of people off the biologic while still on topical steroids. So, it's not for everyone. You certainly monitor it for, but in the past, when we first started it and we got dupilumab for nasal polyp, because that was the first one that got approved, I told them they're going to be on it for the rest of their life. Now I say, well, let's just see how it goes. And in 3 to 5 years, we may be able to have a better idea of where you're going to be at that time.
Yeah, and I would add that, if there are comorbidities, if somebody has a surgery, those things obviously will change because maybe you were able to fix them in a little better way because they were less inflamed on the biologic. Yeah. And then I would also add nasal rinses because that's the other thing that falls off as patients are doing really well that makes it such a huge impact when they restart them.
Dr. Han, do you want to go with the next question?
Yeah, so is there utility in implementing a biologic before a planned sinus surgery in patients with chronic sinusitis with nasal polyp? Meaning, does it make sense to shrink the polyp so you could do the surgery a little easier? And the answer is absolutely yes, right? And actually, we kind of do that for people with nasal polyp already. And so what we do is we give them preoperative steroids, right? Oral steroids. We give them oral steroids for a week, sometimes a little bit longer, sometimes a little bit shorter, to try to reduce the inflammation, decrease the polyp, so that we could do the surgery more easily. Now, can we, instead of doing oral steroids, could we give them a biologic and do that in place? I think the answer is yes. The only difference between the two is the price point, right? So the question is, do you give them, 3 days of prednisone for, $10, or do you give them a shot of a biologic, which is,
But if you want to start them on a biologic anyway,
yeah,
right?
Yeah.
Like you're going to start them on a
Yeah.
biologic for comorbidities or their polyps
Yeah.
or a disaster, or they're going to come
Yeah.
back.
Yeah.
Would you want to start it a month before the surgery?
Yeah, absolutely.
You would? Okay.
So like let's say we have a patient with nasal polyp, and their
EOE
asthma is
or
not,
whatever,
their asthma is not well controlled, or they have atopic dermatitis.
Right.
I would say definitely put
Yeah,
them on
okay.
biologic, so that I don't even have to do surgery, right? So if they have, like, let's say atopic dermatitis, I'm going to give them, dupilumab to treat their atopic dermatitis. That may mean they may not need to do surgery. And like I said, I don't always need to do surgery. I am a surgeon. I love to operate. I do. But if I don't have to operate because they got better with the biologic, with their nasal polyp, well, so be it.
Yeah.
And that's good for the patient.
And then I have a question here about any advice for how to get biologics covered by insurance, for example, what to document in the chart. That's a great question. So I think most importantly, you want to say which medications they've tried. So make sure that you document that they're getting intranasal corticosteroids, because I don't think any biologic will get approved if they haven't tried that, or if they don't tolerate it for whatever reason. So, we have prescribed this, and that, and for whatever reason they don't tolerate it. Antibiotic and oral corticosteroid use, we care more about the oral corticosteroid. That's probably more relevant for the disease, but again, some insurances care about the antibiotics as well. And then objective findings, so sinus CT scan, but then that multidisciplinary approach. So there are some insurances lately who have been asking for the nasal polyp score.
I get rejected all
And
the time.
that's not something, sorry, my microphone. That's not something I can give you, but that's something I can call my ENT and they can give you. And oftentimes, if it's not documented in their note, they can look back at their endoscopy note and they can quantify that for me. Yeah. And then that's usually good enough to get.
Although, if you can see the polyps hanging out of their nose like this, I'll just give you a size 4 on both sides. You're fine. Like, I don't need an ENT to show me that. Yeah.
That's true. That's true.
Yeah.
So I think those are the big things. Obviously, if they've tried another biologic and failed, or if they've tried a biologic and did it really well, and now they're on a new insurance, there was a lapse in care, and you're trying to get it back, I think obviously documenting that as well.
One super annoying thing that's happened to me twice, so I'm now careful about it, is with the surgery. So because they're all of them so far are approved for bilateral polyps, right? So if I decide for whatever reason that with my ENT team that they really do need to go to surgery kind of regardless, and they go to surgery, and then I prescribe the biologic, I've had 2 insurances come back and reject them because now they don't have polyps because he just took them out. So I now will prescribe the biologic before you get surgery. I don't care when you start it, but just you have to still have polyps when I prescribe it. Otherwise, insurance gets mad. Okay. Do you have a comment to hers, or you're good?
Nope.
Okay. So, all right. So next question, and this might be our last one we have time for. This is more of a your vibes. Of the agents in ongoing phase 3 clinical trials for nasal polyps, is there one you're most excited about that you think will add the most to the current armamentarium? Oh. So I'll pick, can I pick 2? I want to pick 2. One is if tezepelumab gets approved, I think we don't have something for those patients. There are those patients you feel like you should be type 2-ish looking to me, but I can't find an eosinophil or an IgE anywhere in you. And I nobody will let me use anything. And I think, those are either patients that there's more variability to their inflammation, or we just need something that works higher up in the system. So I'm looking forward to tezepelumab for those, and I'm suspecting that we're going to get it approved. And the other one would be if the depemokimab actually works, because frankly, 2 shots a year is better than 24 shots a year. So I could see that. If it works, I could see that being cool too. What do you think?
Yeah, no, so I think what we have is benralizumab, and that should be coming out. And then we have the Anchor 1, Anchor 2, which is a depemokimab, and I completely agree. If you ask patients, Q2 versus Q2 weeks versus 4 weeks.
Q year, yeah.
Yeah, 1 month versus 2 months, 6 months, Okay, that's a big deal. And then same thing with tezepelumab,
yeah.
because you have these people where they do well, but there's these couple of people that just don't fit in, and so so it'd be nice to see if Tezi can kind of help treat those patients. So completely agree.
And I agree with those two. I will say, you know, even though the benralizumab targets the same pathway globally as mepolizumab, we have seen in asthma that there are some patients that, you know, will respond better to benralizumab than mepolizumab, you know, whether it's the killing of the eosinophil or whatever it is, but I won't write the IL-5 receptor alpha yet, write them off yet, so.
Good. I think we've gotten there. Thank you, everyone, for your participation. Much appreciated.
Good work, Queen.
I'm taking my home.
Good job, Yellow, yay.
I'm an unbiased cheer.